Good evening, everyone. Welcome again to the McLean Hospital Borderline Personality Disorder Family and Patient Education webinar. Tonight's topic is going to be on borderline personality disorder and substance abuse, and we're pleased to have Dr. Rocco Iannucci, who is the director of the Fernside program here at McLean Hospital, which is a alcohol and drug abuse treatment program. So it does not specialize in borderline personality disorder. So we're calling upon his expertise as a substance abuse clinician to speak with us about how substance abuse can affect borderline personality disorder. Before we get started, a few logistical announcements. All of your microphones have been muted, and nobody else can see your name or email address or phone number, but we do encourage your participation. So if you have come with questions or if questions come up during the session, please type them in the lower right-hand corner in the Q&A box. If you've come with a specific question in mind, you can feel free to enter it right now, and we will put them in queue and get through as many of those questions as we can. In the lower left-hand corner of your screen, you'll see several links. The first link is to our website. So if this is one of the first times that you are joining the webinar, we have archived many other webinars on a lot of different topics. You can go to that website and view any of the archived webinars on other topics. The next webinar is, if you're interested in our upcoming webinar on January 12th, that is going to be Dr. Alan Fruzetti, who's going to be speaking on borderline personality disorder in boys and young men, which, at least in the United States, is really an emerging topic. Most clinicians here in the United States don't think about men or boys having borderline personality disorder, but this is a kind of a breaking area of the field, and he'll speak to that. And then the next three links in that lower left-hand corner are all treatment resources. So if you are in need of treatment in your area, you can use some of those resources. The Borderline Personality Disorder Resource Center actually has a call-in line. You can call them and ask them if they are aware of any resources in your area. And then finally, this entire project and these webinars are funded by a philanthropic gift by a family that was affected by borderline personality disorder. And we would love to be able to continue these indefinitely. And so if you're in a position to be able to help support these webinars, we would ask you to consider making a gift, large or small, and you can click on that final link in order to do that. But with no further ado, I'm going to turn the webinar over to Dr. Iannucci, who again will be speaking with us on substance abuse and borderline personality disorder.
Thank you, Chris. Welcome, everyone, and thank you for joining us today. So, yes, my focus will be on borderline personality disorder as it relates to substance use disorders, and I will be speaking about substance use disorders more generally as well. How I plan to structure this session is to present a few slides, introduce some topics, and then pause from time to time for questions if there are any. So as Dr. Palmer had requested, just type them in as they come up, and we'll answer them as many of them as we can, as thoroughly as we can. There'll also be some interactive polls, a few poll questions during the course of the talk as well. So in terms of outlining today's session, I'm going to talk about the conditions, substance use conditions, more quickly about borderline personality in light of other talks being more focused on that. And I'm going to spend a fair amount of time talking about the interaction between the two conditions, how they, one can actually exacerbate the others. We'll look at an overview of treatment, both for substance use conditions in the general case, as well as what's currently known about treatment of co-occurring borderline personality disorder with substance use conditions. We do have some information now to guide treatment, at least to some extent. And then there are some resources that hopefully will be useful to folks who have been struggling or trying to connect with help for this problem for a loved one or for themselves, perhaps. So next slide. So the first question which of the following, harder to read it, which of the following would not be considered a formal criteria for BPD, borderline personality disorder, or substance use disorder? A, drinking 4 or more beers daily. B, impulsive alcohol binges associated with risky sexual behaviors. C, repeated unsuccessful attempts to cut down on alcohol. D, a sense of not knowing who I am with a personality that shifts in part based on social context. So just put in your answers. Okay. Drifting a little bit, but it looks like most people chose A as a criteria of neither borderline personality disorder nor substance use disorder, and that's correct. We don't have, as a part of substance use disorder criteria, an amount of intake per day, or even does it have to be a daily intake. So next slide shows the criteria for substance use disorders, and they reflect a constellation of symptoms in several domains. Generally, there's loss of control over use, so attempts to cut down where there's an inability to cut down, drinking or using substances in a greater quantity over a longer time period than expected. There's use in risky situations, so for instance, operating machinery or driving a vehicle while intoxicated. There's generally a failure to fulfill role obligations or social problems connected, that's a work-related, relationship-related problems caused by substances. And then there are pharmacological criteria, cravings, high tolerances or augmented tolerances, and withdrawal symptoms. So in describing these conditions, we describe substance use disorder, so alcohol use disorder, not alcoholism, opiate use disorder, not opiate addict, being an opiate addict or an addict. These are terms that are more medicalized, which makes sense based on the illnesses and based on the identity of these things as illnesses. And also, there's less stigma attached to them. They can oftentimes be more acceptable for a person to consider the medical illness. The other thing I would say is when talking to loved ones and when asking yourself about whether there's any problems connected to these that you or a loved one may have, it can be helpful to think about problems caused by the substance as opposed to having a problem with a substance. The latter really, again, implies a certain potential for stigma. What's your problem? You have a problem. Nobody likes to hear that they have a problem, but it is more of a function of, are these things worth continuing to use? Are they causing you problems where it gets to a point where a change is necessary or could be helpful for you? On the next slide, I put criteria that folks may already be familiar with for borderline personality disorder. So borderline personality disorder describes a generally chronic, although there's certainly remissions and there's waxing and waning of symptoms. It's a condition where there's essentially a hypersensitivity and a reactivity to emotions, particularly to negative emotions, and particularly in an interpersonal context. So abandonment fears are oftentimes a prominent symptom. Worries about breakups, worries about having enough closeness in intimate relationships. There's oftentimes an unstable sense of self where the person feels like they're different, or their personality kind of disintegrates away from other people, or the personality shifts depending on close contacts. Relationships, as a result, tend to be stormy. The internal sense of self is stormy. The connection to other people tends to be similarly unstable and stormy. There's impulsivity in ways that can be quite hazardous. So, dangerous driving, impulsive sexuality or relationships. Drug use can be a criteria, or substance use can be a criteria of borderline personality disorder. Suicidality and self-harm, it's the only diagnosis that actually has that as one of the criteria, is self-harm and recurrent suicidality. Oftentimes there are chronic feelings of emptiness, anger outbursts, and usually brief and less severe periods of paranoia than you might see, for instance, with schizophrenia, and periods of dissociation as well. Next slide. So another question. In an 11-year, In an 11-year study of heroin users, BPD was associated with A, persistent heroin addiction, B, a higher risk of needle sharing and consequent medical problems, C, worse mental health status, or D, all of the above. you're good again. And say oftentimes in these sorts of talks, if there is an all of above, pick all of the above. So it's true. They had worse outcomes even over the course of 11 years. It was one of the more salient risk factors for having these negative outcomes in this particular study. And we think in the general case for people with substance use disorder, so having borderline personality disorder conferred this increased risk of worse outcomes and just more difficulties getting into recovery for people. I have more, better news a little bit later on, but there's certainly reasons to be concerned and reasons to address these conditions. So next slide. Something's up there. So there's a common and problematic association between borderline personality disorder and substance use disorder. So borderline personality disorder in the general population has a prevalence of somewhere around 3%. In folks with substance use disorders, it's closer to 10%, and even higher than that in some studies. It really depends on the population that you're looking at. Conversely, alcohol use disorder has a lifetime history of alcohol use disorder. So folks who have had alcohol use disorder at any period in their life are represented in about 30% of Americans. For drug use disorder, the figure is about 10%. For people with borderline personality disorder, it's about 50 and somewhere between 30 and 50. So 50% of people have a history of alcohol use disorder. Somewhere between 30 and 50% have a history of a drug use disorder. So clearly, having one illness confers an elevated risk of having the other. There's also an interaction between the two disorders where there's lower remission rates connected to having one disorder. So a person with an alcohol use disorder with borderline personality disorder could be expected to have a somewhat worse prognosis in terms of being less likely to stop drinking, less able to stop drinking. Someone with borderline personality disorder who has a co-occurring substance use disorder is less likely to go into remission. So the next slide, if you look again at the symptoms of borderline personality disorder and just think intuitively about what substances do, this actually makes sense. So looking at some of these symptomatic criteria, people who use substances often have stormy relationships. So there's some overlap there between the substance use and the personality disorder. It's hard to have a sense of yourself if you're altering your cognitions, your emotions regularly with the use of substances. So you're not going to be able to develop a strong sense of self. And we see that pretty regularly in people with substance use disorders when they've developed at an early age. Impulsivity, you think about folks when they drink alcohol, they're more likely to do things that they wouldn't otherwise. So you can actually, in a sense, add fuel to the fire of borderline personality disorder, exacerbating that symptom that the person already has of being more likely to be impulsive in a potentially hazardous way, making it that much worse. You can think through this list and think about what it's like when people take different substances, and it makes intuitive sense as well as being borne out by research. Particularly important on this list is suicidality. We know that folks with substance use disorders have an elevated risk of suicide. People with borderline personality disorder have an elevated risk of completed suicide, of actually dying in a suicide attempt, as well as a risk of other self-harm where they don't die, either in suicidal or what we call parasuicidal acts. The two act synergistically in a negative way. So having a substance use condition and having borderline personality disorder, we think there's an additive risk where those folks are at much higher risk of suicidal acts and of death by suicide. We also know that many cases of suicide attempts involve ingestion of a substance. So there's already a substance oftentimes in the person's system before they follow through with a plan or an impulsive suicidal act. So next slide. There is some good news. Certainly we have good treatments for substance use disorders. We have good treatments for borderline personality disorder. We know borderline personality disorder in the general sense has a fairly good prognosis where a lot of people get into symptomatic remissions. At least many of the symptoms of borderline personality disorder can come into remission. And overall, even in the most serious conditions, serious substance use conditions, for instance, heroin use disorder, that same study that I referred to earlier, the 11-year study, did show improvement over time where many people did get into remissions. We know that's true for, there's a longitudinal study here at McLean showing that folks who were admitted initially to the inpatient services with borderline personality disorder, so people who were fairly symptomatic, to get into a hospital, generally you have to be fairly ill. Oftentimes there's acute suicidality or something on that scale. And yet 90% of them in the longitudinal study over years were able to achieve a remission of substance use disorder. There's some thinking that in that particular population there were represented milder substance use disorders, or at least some of the folks in there had milder substance use disorders. So for someone with a severe substance use disorder, we may not expect a 90% chance of recovery, but there is still some good news there. We're also starting to learn now about what sort of treatments can be helpful for people with both conditions, where there are some specialty psychotherapies that have been developed to try to address both in an integrated fashion. So this may be a good point. If there are questions, I can pause for a minute and see if there's a question or two. If not, I'll just keep going.
We definitely have several questions. If you want to start taking them, so this one has actually come up before as well. So this is about people diagnosed with borderline personality disorder and substance use problems and having tremendous difficulty accessing care. So this particular person says, our daughter has BPD and substance abuse problems. Facilities for substance abuse won't accept her because of her BPD symptoms, even though they claim to be dual diagnosis programs. And psychiatrists don't want to take her on as a client, as an outpatient, because of her substance use disorder. And so what is a patient or family to do?
So it's a significant problem. It reflects the traditional silos that developed in healthcare and in mental health care, where in particular there was a wall built up between substance use treatment and other mental health problems. And I say other mental health problems. I think the terminology was often mental health and substance use. Substance use problems are mental health problems. And thinking about it, the issue is understanding that folks with borderline personality disorder have such a high rate of having substance use problems. And the other way around is true as well. It's an artificial separation. Folks go to, if you work in the substance use setting, even if you're trying to have only folks with substance use disorder, it's impossible. It's not something that actually works. So there are some facilities, there are places that specialize in true integrated care of co-occurring illnesses, including dual diagnosis. I don't know if this is a situation where McLean services are something that you can't access geographically or otherwise, but McLean Hospital would be one place where folks can get treatment of both. It may make sense, if you don't have other options, to look at which condition is more severe, and that's the direction to start in. If they're both similarly severe, a lot of times, at least in DBT, for instance, there's a treatment hierarchy where suicidality, if there's suicidality that's currently ongoing, then starting in the inpatient psychiatric facility from a practical perspective can be the most accessible way to go. So I will talk about specific treatments that may be helpful. You can look in that direction potentially in your area, and I will give resources as well at the end for how to connect with treatment at McLean and investigate that further if it's something that's practical in that situation.
Great. We have several more questions, but do you want to...
We can move on.
Move on with
the
presentation.
Pause a few times, so sure.
I think we'll have plenty of time for more questions.
Sure, okay.
Great.
So I want to move on into thinking about specifics of treatment. So I'm going to talk about treatment in a general sense for substance use conditions, and I'll also talk more specifically about what we do know about treating co-occurring borderline personality disorder with substance use disorders. I won't speak as much about treatment specifically for borderline personality disorder in the absence of substance use disorders. I'll refer to that a little bit, but I do just want to say as a summary statement, there are clearly empirically demonstrated effective treatments for borderline personality disorder, and there's no reason not to engage in those if that's what's available to you, even if your loved one may have a substance use condition as well. Many of the major trials of the evidence-based treatments for borderline personality disorder didn't at least completely exclude people with substance use problems. And so then, you would think the results, the positive findings they have, would be at least somewhat generalizable to folks with substance use conditions. So I'm going to start with talking about medications, and I'll pause for some questions on medications. Then I'll talk a little bit more about psychotherapy, and that's where we have the most research available to guide treatments right now. And then last, I'll talk about the place that self-help may have within treatment of these co-occurring conditions. So what do we know, move into thinking about treatment specifically for substance use disorders. We don't know a lot about the treatment of co-occurring borderline personality disorder and SUDs with medications. Not many studies. There was a study that took a look at naltrexone or disulfiram in folks who did have borderline personality disorder and alcohol use disorder, and folks who did not have borderline personality disorder and alcohol use disorder. And they found it did not make a difference, that people were able to, there was no difference in benefit from medications with naltrexone or disulfiram, depending on the patient's characteristics. Naltrexone was used in some, it was looked at a little bit, I think, with mixed results for cutting. So there's reason to expect that naltrexone at least would be relatively safe for borderline personality disorder, and there wouldn't be a contraindication. Disulfiram I'll talk about a little bit more. That one study did find that no difference, no real concerns about it, but there may be, I think it has to be prescribed in the general case thoughtfully and carefully, and that's particularly true if someone also has borderline personality disorder. So let me say a little bit about what these medications are and where their place is in the treatment of alcohol use disorder in general. So I'm going to talk about alcohol use disorder, its treatment with medicines. I'll talk about opioid use disorder, and I'll talk about nicotine use disorder. Those are the conditions for which we have FDA-approved treatments at this point. Other conditions, things are in a more experimental phase. There's oftentimes results that are more mixed, where it's not clear exactly the best direction to go would be. There's certainly hopes that things are on the horizon where there'll be more effective medications for other conditions, but there are effective medications for these conditions, and certainly alcohol use disorder and tobacco use disorder are both the most common substance use disorders in the country, and also the most common with people with borderline personality disorder. So of these medications, naltrexone is an opiate blocker. So why would that help folks with alcohol use disorder? The thinking is that in particular where there's a strong biological loading, so perhaps a family history or a very early onset of alcohol use disorder, there are some abnormalities in the endorphin and opiate system. So the endorphin system are the natural high chemicals. So there's abnormalities in that system such that it actually gets activated by alcohol. So one way to think about this is some individuals with alcohol use disorders, their body may react to alcohol similarly to someone else's body reacting to heroin or OxyContin. So by blocking that opiate receptor, it blocks some of that reinforcement. That's not likely to be the only pathway of benefit from these medications, but they've been shown to be effective in several clinical trials. And as I said before, it looks like there's not a difference between people without borderline personality disorder in their ability to respond to that medication. That comes in a once-a-day pill or a once-a-month shot Vivitrol injection. So it's fairly easy to take. Side effects really have to be discussed, I think, individually with a prescriber. That medication is fairly accessible. Psychiatrists certainly prescribe it. A lot of primary care providers are comfortable prescribing, in particular, the pill, and that's something that may be very accessible to folks out in the community if you're struggling to find care for these conditions. Camprol, acamprosate, is another medication. We think the mechanism by which that medication works is by rebalancing essentially a couple of brain chemicals that are involved in alcohol use disorder, and that regular drinking tends to throw off the balance of. That's GABA, which is a relaxing brain chemical, and glutamate, which is a more stimulating brain chemical. Rebalancing the two, essentially settling down, we think, some of the cravings for alcohol. And again, we've had several large, well-designed trials that show that can be an effective medication for folks with alcohol use disorder. And finally, Antabuse. Antabuse is one that there may be some familiarity with. That's the medication, if you take it regularly and you try to drink on it, if you ingest any alcohol at all, you can get quite sick. Flushing, nausea, vomiting, or even more severe and sometimes dangerous reactions. It's an effective medication if taken. It does have a more serious potential side effect profile, including some severe reactions if people do drink on it. That was included in the study that I referenced, and again, no difference between people with BPD and without BPD in a 12-week study. I think you want, my own sense as a clinician and my own practice as a clinician is that one would want to be fairly careful in prescribing Antabuse, thinking about how impulsive is this person, has there been efforts to self-harm or to even commit suicide. If it's someone who get some relief from physical pain, there might be temptations to try to drink on the Antabuse. And so you'd want to take that into account in making a decision about whether that's a reasonable medication for that individual. And then topiramate an off-label, so this is not FDA approved. There have been a couple of studies showing that it can be useful for alcohol use disorder, binge eating disorder, and you know, I would defer to the people who really specialize in borderline personality disorder. There have been some studies where it's had some promising looking results for things like mood and borderline personality disorder. I do know from conversations with borderline specialists that the enthusiasm of the clinicians doesn't quite match what the studies look like, so I think clinical practice hasn't borne out those effects. It can be a useful medication for some individuals with alcohol use disorder, though. So, next slide. So another area that I think I can't really overemphasize the importance of medications in opiate use disorder. What we know about opiate use disorder, I think it's not really too much of an overstatement to say that medications are a pivotal part of treatment for many individuals with opiate use disorder. I did not mention Narcan up here because it's not a specific treatment for the disorder, but it's worth talking about at least. Narcan is a medication that can reverse overdose, reverse an opiate overdose. It comes in very simple formulations, just a nasal spray, pre-set up is available right now. And for someone who has a family member with opioid use disorder, it could make the difference between life and death. You can get it in many states without a prescription. You just get it for yourself to use for your loved one. So ask at different pharmacies. Most of the national pharmacies can get it, or you can ask your own doctor or primary care provider or your loved one's physician for that medication. Naloxone, naltrexone, similar medications. That's similar medications with the Narcan. It's the opioid blocker. With the opioid blocker, it makes it so that folks are not able to get high, potentially not at all, and at the very least not as easily. They also tend to drop cravings, potentially by allowing the person to know that they don't have access to the substance of choice, to the opiate anymore, because it's not likely to work in the same way if there is a blocker on board. And the once-a-month injection, Vivitrol, it can be particularly helpful for opioid use disorders. All that person needs to do is make that right decision once a month to get the shot, and then they can be blocked for an extended period of time and protected against many of the effects of opiates. Suboxone Subutex are versions of buprenorphine. The Suboxone has naloxone as a component of the medication. The mechanism of action of buprenorphine is as a partial agonist-antagonist. So what it essentially does is it binds fairly tightly to the opiate receptor so that other opiates are not as likely to be effective or not effective at all. So essentially the person is blocked from use of opiates. But it also stimulates the opioid receptor to some extent, so they get some opioid effect, and that blocks cravings for some individuals in a more detectable way than the naloxone may. For some people, the naloxone works just as well. Very effective and helpful medication. It also has a ceiling effect so that overuse doesn't really get the person any kind of euphoria or any kind of a high at all. The addition of naloxone means that people can't effectively grind it up and inject it because then the blockade effect kicks in and they just get sick. So, so a very useful medication, obviously not for every single person, but quite helpful for many people. And there's methadone, methadone is the long-acting opiate that's available in the United States. It's also quite effective, quite helpful, very long track record. It tends to be somewhat more onerous to try to access. Generally, folks need to go to a methadone clinic every day to get dosed with methadone to get their medication. They don't get any to take home until they've had a fairly extended period of connection to a clinic in most places. So, so the reason I said that you can't really overstate the importance of these medications, you do see a fairly big difference in outcome, at least in the early stages, and up to 2 years in individuals who take medications versus those who don't take medications. So medications have the biggest effect on opioid-related illnesses, opioid use disorders, especially severe opioid use disorders. The difference between being on medicines and not being on medicines for someone with an opioid use disorder is a different thing than for someone with an alcohol use disorder, where the difference isn't quite so large. It's significant, but not quite so large. So it's important to consider them if someone has opioid use disorder. So, and lastly, I'll talk about tobacco use disorder. So again, it's the next slide. It's the most common. It's the most common substance-related condition that in mental health. Period. Within people with substance use disorders, within people with mood disorders, schizophrenia, and within people with borderline personality disorder. So very important to consider these. There's not really information on specifically people with co-occurring nicotine, tobacco use disorder, and substance use disorder. But there isn't really a reason not to think about, in particular, nicotine replacement for folks if it's clinically appropriate and medically appropriate for them. There are different forms of nicotine replacement. People have a preference. Sometimes someone has tried the patch, it didn't work for them, but the gum does work. Some combination of the two. If someone is very dependent on nicotine and smokes a lot of cigarettes a day, I mean, you have 2-pack per day smokers, they sometimes need quite a bit of nicotine to be able to get over the cravings and not smoke. There's also an inhaler, which some people like because it substitutes some of the hand-to-mouth and some of the rituals of smoking the cigarette. And it can be a good transition to get away from the cigarettes onto the inhaler and then finally off of nicotine replacement. Now, I'm not talking about e-cigarettes. I'm not talking about, there's a specific prescription inhaler. It's different than e-cigarettes. I'm not recommending e-cigarettes to help people stop smoking. Bupropion is it's used generally under the name Wellbutrin as an antidepressant, but it's also an effective medication to help people stop smoking. And then Chantix or varenicline is another medication that's useful. We think it may be a little more effective than the other medications, but it's got a side effect burden. Some people have described even psychiatric decompensations on it, and it clearly gives people vivid dreams. So someone who has a history of trauma-related dreams might have a tough time on Chantix. But it's useful. You know, sadly, a lot of our folks die and get ill with tobacco-related illnesses. That's really one of the most threatening things for a lot of individuals. So it makes sense to use whatever is effective for that individual. Each of these medications roughly doubles the odds of being able to quit using tobacco. So next poll question, true or false, there's no evidence that 12-step treatments are effective for the combination of borderline personality disorder and substance use disorders. You guys are good. 5 people so far. Let's see where it lands. Yeah, so we have I don't know if other folks can see the split. It's somewhere on the order of 80% true to 20% false, and it's actually the other way around. So there is evidence that 12-step treatment has some potential effectiveness for BPD with SUD. Now, it's complicated evidence. It's indirect evidence. It's not a randomized controlled trial. It's not that level of evidence. So, but it wouldn't be accurate to say there's no evidence that 12-step treatments can be of benefit. And I'll talk a little bit more about that coming up next. Why don't I pause for a minute? Do I meant to pause for questions, or do you think I should just march on and finish up?
I would go ahead and march on because you've got lots of questions. So
all right, let me do that, and then we'll just do questions to the end. Yeah. Sounds good. So evidence-based treatments, as I mentioned before, there are multiple evidence-based treatments both for substance use disorder in isolation. There are multiple evidence-based treatments for DBT in isolation. And the combination of the two, we're starting to learn more about how to treat. So there have been several trials of dialectical behavior therapy in individuals with different substance use disorders, primarily opioid use disorders, but also people with multiple addictions, so opioid use disorders and plus cocaine or plus alcohol or plus other stimulants. And those studies generally showed improvement in substance-related outcomes as well as improvements in psychiatric outcomes. None of the studies are perfect in terms of design, and I'll talk a little bit about that and what that means for the, it's particularly related to the control treatments at the end. But there was some evidence to suggest this would be a helpful approach. This is useful information because DBT is fairly accessible, not everywhere, but it's a fairly well disseminated treatment. We know that it works for DBT. I mean that's I think it's at this point perhaps the gold standard for many individuals with borderline personality disorder. So it's helpful to have some evidence for it. As we think about the evidence for these different treatments, what do you actually want to know? So you can think about that at different levels, and the experiments are designed to essentially ask different questions. They tell you different things about the different treatments. Do people get better? So if someone enters treatment and they kind of keep going with treatment, do they get better at all over the course of treatment? So that gives you a certain amount of information about the treatment. And each of these three studies has shown evidence of having people get better in the course of treatment. Do people do better with this treatment than they might be with something else? And that something else is typically treatment as usual. So if you just let somebody get treatment out in the community, whatever the best they can find is, compared to a well-designed manualized treatment, which one does better? Are you actually able to do better with the manualized treatment? And then, even higher level of either higher standard is take an already effective treatment. So a treatment that works for folks with one or both of these conditions. Manualize it, write a manual for it, train everybody, and supervise how that control group is actually delivering the treatment, and then see if your treatment can beat that. So that's a much higher standard. To summarize these studies without going into each study, each of them showed improvement. So DBT, dynamic deconstructive psychotherapy, and dual focus schema therapy all showed improvements in folks in substance-related domains. So the substance-related behaviors got better, and in their overall psychiatric status, that also got better. How well the treatments looked depended on that control group. So were you just trying to demonstrate movement over time? Were you looking at general community treatment, just whatever happens to happen in the community? So all three, so dynamic deconstructive therapy and DBT looks quite good compared to that, just sort of community treatment and seeing what can happen. When treatments that have been used for substance use disorders were used as the comparison group, those treatments actually did fairly well. So the two that ended up looking the best were 12-step based treatments, and this is where I'm saying there's some evidence for 12-step based approaches. So there was a study comparing DBT for substance use disorder with comprehensive validation plus 12-step, essentially referrals and engagement in 12-step. And DBT did do better, but the 12-step based treatment did fairly well in that group of individuals. Similarly, dual focus schema therapy, the person who designed that really made his job fairly hard by comparing it to some already effective treatments that we know work for people with substance use disorders, something called individual drug counseling, which is essentially a treatment that focuses on identifying triggers and working on the environment to try to improve it and make it a little safer for people. And also compared this dual focus schema therapy to 12-step facilitations, which is a treatment that tries to engage people in 12-step groups. And it was hard to separate from those two treatments. We know those two treatments work. So I'll run through what these treatments are kind of quickly and describe them, but I would say any of these would be reasonable for what we know, and DBT probably has the best evidence. It probably has the best evidence for each of these for treatment of borderline personality disorder by itself, and also the strongest evidence as a treatment for borderline personality disorder with different substance use disorders. So DBT itself is a treatment that is at heart a behavioral treatment, so it works on things like reinforcement patterns for different behaviors, on skill building, learning, trying to build skills in areas, for instance, learn skills that could substitute and perform some of the roles that substances did for, say, emotion regulation for the person. And it does that in the context of dialecticals, which are essentially trying to embrace and kind of hold in mind at the same time seemingly opposing things. And one of the examples specifically used in DBT for substance use disorder is the idea that abstinence is the goal, but also there might be lapses, and those should be addressed. So you hold those two things in mind at the same time, and the treatment philosophy and the treatment approach represents that. So dynamic deconstructive psychotherapy is a little harder to describe briefly. In many ways, it's a very traditional psychotherapy, and it works to try to help people connect, to form a cogent narrative of how their feelings connect to each other and how their feelings connect to life events, and then navigate the relationship with other people, primarily in the room with the therapist, navigate the relationship with the therapist, and then generalize that to the world. So learning to help differentiate closeness versus a need for having a safe distance for other people, which can be something that's difficult to navigate for people with borderline personality disorder, and to have a better understanding of oneself, a more integrated understanding of oneself, your emotions, your reactions, as well as the other person, both the good and the bad. So in many ways, kind of a traditional psychiatric approach, and one that had some good outcomes compared to community-based care, which is a somewhat lower standard as a control group, as a comparison group. And then finally, dual-focus schema therapy is a treatment that's evolved from cognitive behavior therapy, so looking at the interactions between our thoughts, our behaviors, and our emotions, and in particular working on our thoughts and some of our behaviors to try to improve our emotional world. So those approaches, in conjunction with some more traditional, and integrated with some more traditional relapse prevention techniques from the substance use world. So any three of these is a reasonable approach if it's accessible in your area. From a practical perspective, it's not unreasonable to try parallel treatments, to try to connect yourself or a loved one with substance use treatment, with self-help groups, at the same time as being connected with psychiatric management of borderline personality disorder and DBT or transference-focused therapy or mentalization-based therapy, something else that's accessible in the community where you are. So next slide. So then I want to say something about self-help resources. So I mentioned 12 steps. There was some evidence for 12-step approaches. These were psychotherapies, though. They were specifically managed by clinicians who encouraged groups or facilitated the connection with groups. We don't really have the same evidence for people with BPD and connecting to 12-step groups. And there's some thought that maybe they may not connect as well. It's something that we're hoping to look at a little bit more ourselves as patients come through, just to compare folks with BPD to folks without BPD and how helpful some of these resources are. I think it's important to understand that 12 steps are one approach to self-help groups, and even within the 12-step approach, there are different types of groups. So if someone goes to a particular kind of meeting or even a particular meeting, they may go to another where they can relate better to people. They may go to another where it's a different kind of meeting. Some meetings have a speaker in front. They're not very interactive. Others are meetings where it's the same people meeting every week, getting to know each other and having the social support. The building of social networks seems to be a fairly common element in many types of treatments that's helpful. A sober social network, and that's something that can come from self-help resources. So beyond that, 12 steps are only one kind. There have been other kinds of self-help groups that have developed for individuals who don't like 12 steps, or that the 12 steps just don't serve them well. They don't work well for every person. So if you have a loved one who has been reluctant to connect to self-help, they could look at some other types of self-help. SMART in particular has a really different approach than 12 steps approaches. So it's focused more on an internal locus of control, meaning taking charge of the illness and taking charge of the recovery. That's something that some people respond negatively to about the 12 steps, where they feel like needing to accept an inability to control the illness is something that they just can't do. They have a hard time with that, or they want to have more of a sense of agency. So SMART recovery is really based more in those cognitive behavioral principles, looking at how thoughts and behaviors are connected to actions. It is sometimes somewhat more tolerant of non-abstinence-based approaches, so it's something to keep in mind. But it can be a useful option for a lot of people. Dual Recovery Anonymous is a 12-step approach, but it's a 12-step approach that takes into account mental health as well. So that can be a useful thing for some folks with BPD who are looking for resources to help them in recovery. Refuge recovery is relatively new, well, I guess I should say it's new in this area, but more and more groups are starting to come around. They describe themselves as a Buddhist path to recovery. There's a focus on kind of wise thinking in the same terminology that's used in DBT, so wise mind, and a focus on mindfulness. So folks who really find the DBT model helpful, it may be worth checking out to see if Refuge Recovery is a self-help group that's useful for you. And there's Women for Sobriety. They have 13 steps. They're different than the 12 steps, so they're not just 12 steps specific to women. It is a little bit more of an internal locus of control, kind of taking control of one's life, one's wellness and one's health, and it can be a useful thing and something that connects with some folks who don't connect to other types of self-help. So I don't know if there's time for this. I wanted to speak briefly about, I guess, positive news. So the program that I run, McLean Fernside, we've been taking a look at how our folks do who have borderline personality disorder. Everyone who comes through our doors has substance use disorder. And I would describe our treatment as borderline personality disorder informed treatment. So it's not a program for specifically borderline personality disorder, but we try to include an awareness. We try to include elements that would be useful for folks. And we try to practice in a fashion consistent to John Gunderson's good psychiatric management of borderline personality disorder, which is a model that you can adopt to substance use care, in facilities where the main focus is not borderline personality disorder. It works quite well. So I just wanted to show a little bit on in-treatment outcomes, and we're working to extend this to post-treatment outcomes so we have a better understanding of how people do. Next slide. So we're a residential program for the treatment of substance use disorders and co-occurring illnesses. Most people have treatment refractory substance use conditions, so they've tried other places, they've tried other treatments, they've just not been able to sustain or attain sobriety. We have cognitive behavior-based treatments. We also have treatment specific for people with bipolar disorder and substance use disorder and other mood disorders, as well as DBT skills groups. So DBT is an integral part of our program, and there's fairly intensive one-on-one work as well. So that's what the program looks like. Next slide. And well, I skipped through this. So I'm talking about folks with BPD and how they've actually done. Most people complete treatment, and that was the case in another study that looked at folks in detoxification, that people with BPD were able to complete treatment. They did have some trouble connecting with aftercare. That was more of a problem. They didn't necessarily go to their appointments afterwards. But within treatment, they did fairly well. Most of our folks completed treatment. Everyone was abstinent in a residential program, which is a somewhat trivial result. In residential programs, most people tend to be abstinent from substances during the course of that treatment. So next slide. And this just shows you general psychiatric functioning. So the basis 24 is essentially a measure of impairment, of psychiatric impairment and functional impairment. You can see that folks significantly improved, and that difference in numbers is clinically meaningful as well. You can tell the difference between a person who has a basis 24 score in the higher range versus in the lower range. The blue are the entering treatment scores, and the red are the after treatment scores. And the quiz score is just a measure of depression symptoms. You see that improved as well, going from a fairly severe range into a mild range of depression. So this is in a substance use, primarily a substance use treatment facility that does understand about treatment of borderline personality disorder as well, but it's not the main focus. So my point is that it's not unreasonable to enter in one area or another if that's what's available to you. If what's available to you is treatment of borderline personality disorder, and both the risk inherent to both conditions at that time is similar, then it can make sense to enter treatment in that way if that's what you have available. You can also enter it from the other direction. We consider ourselves more of an integrated treatment, though, where we really do try to tackle the borderline personality disorder using dialectical behavior therapy as an evidence-based treatment, as well as principles of good psychiatric management, and integrate that treatment with good substance use care as well. That really happens. I'm showing you data on the McLean Fernside program, but that happens throughout McLean Hospital in the division of drug and alcohol abuse. We really are focused on integrated care of co-occurring illnesses. So if you look at the outpatient programs, the partial hospital programs, any of the residential programs, you'd find a similar focus. And we haven't pulled all the results yet. We will, but I would expect similar improvements. So the follow-up on this, we're collecting outcomes at 3 months, 6 months, and a year post-discharge, and hoping to find out how people do afterwards with BPD and co-occurring substance use disorders. So the next couple of slides I'll mention really quickly, and I think these are being provided to folks as well. I wanted to put specific phone numbers down. Guidelines for families, this was something developed in part by Dr. Gunderson. It's really helpful, I think, for families of people with BPD, but it applies well to substance use disorders as well. So we give it out to all families who come through if their loved one has BPD, anyone that comes through Fernside, and find it very useful to talk to families about. It's, I think, 14 or 15 pages. It's a fairly quick read and really, really helpful. And it's available online. The website's right there for free. You can look at McLean Hospital's clinical services at the second web address, the www.mcleanhospital.org, clinical services. The Division of Alcohol and Drug Abuse is a division where we treat certainly substance use disorders in isolation, but a big focus on integrated care, a focus on dual diagnosis, co-occurring illnesses. McLean Fernside is part of the McLean Signature Recovery, and those residential programs can be reached at that number. All the residential programs at McLean can be reached at the number below. So there are folks. There's a residential referral coordinator. If you think your loved one needs residential care and you're not sure which program at McLean makes the most sense, they can help you navigate our system. So the next slide, I put, if you're curious about some of the self-help resources I mentioned, or if you think a loved one might be curious, you can actually get a lot of information online before you even show up at a meeting, see if it's something that sounds like the philosophy would suit you, or be something that you or your loved one would be open to. These websites also tell you where and when meetings are taking place, so each of them has a meeting finder as well, so you can figure out what's in your area and when it's happening. So thank you. I'll stop now for questions.
Great. So thank you very much, Dr. Iannucci. That was a great presentation. We've got lots and lots of questions. The first one is kind of a broad question, but I think it's probably one of the more relevant ones, especially for family members. So this particular participant has a 40-year-old son diagnosed with borderline personality disorder who also abuses alcohol and drugs. And she's wondering how long should she remain in a relationship with him, or do you have strategies for her? Because she feels like it's a torturous relationship. He can get really kind of abusive verbally, even though she's trying to encourage him to get help and to seek treatment. He doesn't seem to want to. And I think it's a common dilemma with a lot of people with substance abuse. Right. Not just borderline personality disorder and substance abuse, but so when you have a loved one who's abusing substances and refuses to get help, but for the point of this question, we'll add on and borderline personality disorder is refusing to get help.
It's a common challenge.
Any strategies for how to help?
I'm thinking of a few more resources I wish I had put up there. So we have a family group here at McLean Hospital for folks with family members with substance use disorders. It can be very helpful for this sort of situation. I don't know if it's possible to post anything after the fact, but that's available at McLean Hospital. It's free of charge in particular to families of patients who've ever been treated at McLean Hospital. And there are groups like that, at other hospitals or in other programs as well. It's a difficult situation to be in, and I wish I could say, do these 3 things and you'll be all set. It ends up being potentially very helpful to work with someone who can help you map out which behaviors, the lay terminology is often enabling, but which behaviors might be reinforcing or allowing counterproductive behavior on the part of your loved one to the extent you can control it. You can't control all of these things. And which behaviors could be helpful with giving a nudge in another direction. The other important part of that is taking care of yourself. You can get lost in the world of trying to help someone with a substance use disorder. You can lose your own world in so doing. So making sure that you take care of yourself as well. There are evidence-based treatments to help loved ones. So one in particular called CRAFT, Community Reinforcement and Family Training. You can find practitioners. If you Google CRAFT, you can find practitioners in different areas. And essentially what they do is if your loved one is not willing to get help, they work with you and they help you to do those things, to figure out what's your best path to make your loved one as likely as possible to seek help, acknowledging and knowing that you can't control it completely, and how do you take care of yourself so that you don't end up, being collateral damage essentially in this oftentimes really troubling situations. For some folks, Al-Anon meetings, Nar-Anon meetings can be very helpful as well. So those are pretty widely available and in different areas. So it's something to look at also. So if you call around, I don't know what area you live in, but if you call around family therapists, there are many family therapists who have an understanding of and or a specialization in helping family members with someone with a substance use problem. So it's something that I think ongoing support's really helpful rather than just a few things. There's a good book. I'm not going to remember the entire. There's a kind of a self-help craft book that's out there. It's called Alternatives to Nagging. There's a longer title that I don't remember, but we can I'll send that to these folks as well, so we can put that up and you know what it is to take a look at.
Great. No, I think that's really helpful because we actually have participants from all over the world, and a lot of them in rural areas where they're going to mention craft to their clinicians, and the clinicians are going to be like, "What are you talking about? I don't know anything about that."
And help you with it because it really lays it out.
But I think Al-Anon, as you mentioned, is pretty widely available, and maybe this craft book and maybe just Googling it and getting some more information on websites could be helpful. So the next question, a couple of people have asked about marijuana, and I'm going to ask about both sides of the controversy of marijuana.
Two sides?
There are.
There are like 10.
So I'm going to start with the first one. So our 24-year-old daughter uses marijuana daily, up to 1 gram, for the supposed purpose of calming down and for sleep. She's doing well at college and at work, She claims that marijuana is helpful far more than any approved, prescribed medication she's ever taken. And is marijuana always detrimental somehow to someone with BPD? These particular people say they live in Canada, and it looks like marijuana may be legal. It's now legal in Massachusetts, for those in Massachusetts. And so what thoughts do you have about using marijuana for the treatment of BPD?
Right. Well, so there's no evidence for marijuana used specifically for the treatment of BPD. So it's hard to say anything particularly informative, about that. A gram is a fair bit of marijuana, and on a daily basis. So I can't say there are risks with that level of intensity of ingesting or smoking marijuana. It confers a fairly high risk of having a cannabis use disorder, a marijuana addiction, so to speak. So it's a lot of marijuana to use, and there's certainly health risks and concern about mental health risks with that as well. There's a lot that's not yet known about it in terms of risks are being figured out. Relatively young people, we think the developing brain is probably more vulnerable to long-term effects of cannabis. So that being said, from the information I have, it's hard to say, does she have a cannabis use disorder? Does she not have a cannabis use disorder? That informs the question as well. And she may be right that she's either saying cannabis is really useful for her or that medications are not. Medications are not the mainstay of treatment for borderline personality disorder. So she may be right in saying that medications haven't been that helpful for me. I would encourage her to try, if she's tried other basic psychiatric treatments and they're not working for her, to at least strongly consider trying an evidence-based treatment for borderline personality disorder. So looking for DBT group would probably be the most accessible thing for Canada, I would think.
So I want to follow up on that, because this is a common dilemma when people say, well, I'm using alcohol or marijuana or something else because it helps me, and who are you to say that I shouldn't be using it? Could you step through maybe a couple of key questions that sometimes families or individuals should think about or look at to kind of make an assessment about whether a substance might be a problem? So more like motivational interviewing type questions,
Right.
or how do you think about, because this particular person is saying she's doing well in college.
Right.
And maybe before she started using marijuana, she wasn't doing well in school.
Right.
And so she's going to strongly argue, hey, look at the evidence. I'm doing great.
Right.
And who are you to tell me to stop using this?
So with most substances, we look at those criteria for a substance use disorder. So substances in my field are not necessarily prescribed for every person out in the world. If you think about alcohol, right? Just because I'm an addiction psychiatrist, it doesn't mean that, the American Academy of Addiction Psychiatry does not have a position that we should move back to prohibition of alcohol and no one should use alcohol. It makes sense to not use a substance if it makes sense to not use a substance, meaning if the risks and or the negative consequences of use outweigh any potential benefits that the person is having. The difficulty that you run into is you may have one perspective, she may have another perspective on this. I can't give you any information on cannabis being helpful for borderline personality disorder. There's not so much saying that it's unhelpful, other than, I talk mostly about not substance use, but substance use disorders being a problem for borderline personality disorder. I have less that I can say specifically about cannabis with borderline personality disorder. But, I would look at those criteria. Are there role obligations that the person is not meeting? Are there social problems connected to the substance use disorder? Is there more time being spent on it? Is it sort of consuming the person's life? Is there a loss of control where if they don't want to use, they're able to not use, or are they not able to even pause or curtail the use at all? Is there any evidence of withdrawal? You can get some withdrawal from cannabis if she skips a few days. Do you see that sort of thing? You might with that much cannabis use. So those are the questions. That answers the question about is there a substance use disorder, and that's something that you can ascertain. If you can't figure it, getting a one-time consultation with someone with a psychiatrist, psychologist, mental health practitioner who is kind of open-minded. It isn't necessarily going to say everyone who walks through the door must stop, but is willing to use. Dr. Palmer alluded to motivational interviewing, which is kind of a back-and-forth dance that's done with patients that can help move their thinking in ways that make sense for them and that are helpful for them. So I'm not sure about sort of training family in motivational interviewing. You could sort of try to learn that those sorts of things yourself. I think Dr. Palmer was also alluding to, I don't know, getting into a motivational interviewing approach gets you out of a struggle with the person, which can be really helpful, actually. And that's more of open-minded, open-ended questions, so it's sort of listening to their end of things and just letting them kind of do the work of thinking it out. It may seem counterintuitive. It may seem like those sorts of approaches of like, sure, tell me tell me what's helpful about cannabis for you. Is there any downsides at all? And you're more sort of listening, asking questions, and letting the person kind of do their own work and not coming to any conclusions yourself. It actually can help people move in a more positive direction without getting into that struggle where they dig their heels in and say, no, I'm smoking no matter what, just because of the fight.
Great. So actually, I'm looking at the time, and we have gone a little bit over. So we are going to have to wrap it up for tonight. Thank you so much, Dr. Iannucci. This was really helpful and informative, and thank you all for participating.
Thank you.
And we will try to incorporate those additional links that you mentioned, maybe in the archived resources that we put up.